Okay, we started a little bit late and I talked a little bit long, so I'm going to try to move through this fairly quickly. This is a picture from a recent journal article that was published in the New England Journal by Drs. Walker and myself, and I strongly recommend that you take a look at this article because it talks about some of the more recent updates and some of the things that I'll be talking about here. And here's the situation that we're very concerned about. This is a baby with distended abdomen with some periumbilical erythema, and by x-ray we look at these arrows here, and what are we seeing by these arrows? Can you see that little bit of air in the bowel wall? Pneumatosis intestinalis, and up here we're seeing portal venous gas, very typical of medical necrotizing enterocolitis. This particular baby started to get worse from a metabolic inflammatory perspective, and over a period of time became very acidotic, and the surgeons decided to operate on this baby, and here's what they found. Dead piece of bowel, and this is very typical of necrotizing enterocolitis. That piece of bowel had to be resected. Now, over the next few minutes, I'd like to talk about, give you a little bit of background about necrotizing enterocolitis. I want to leave you with the message that necrotizing enterocolitis is not just one disease. This is very important. We tend to lump necrotizing enterocolitis into just one disease, but it's probably several different diseases. And then I want to talk a little bit about the pathogenesis and very little about the treatment and prevention, and then about some predictive biomarkers for necrotizing enterocolitis. How big of a problem is this? Well, in the United States and Canada, about 7% of babies in neonatal intensive care units weighing between 500 to 1,500 grams develop this disease, and approximately 20 to 30% of these babies die. It approximates the number of children fewer than 15 years of age who die of leukemia and meningitis. Just to put this in perspective of other pediatric diseases. Survivors may be left with significant sequelae. We usually think of the sequelae of necrotizing enterocolitis being a short gut, but there are other sequelae that are very important. And we are now finding that babies who develop necrotizing enterocolitis, especially surgical necrotizing enterocolitis, have significant neurodevelopmental delays. This is a very costly disease. Each episode of medical necrotizing enterocolitis increases the cost of hospitalization by $30,000. If the baby develops surgical necrotizing enterocolitis, it increases the cost by $300,000. And a baby who is left with a short gut, it costs approximately $1.5 million to take care of that baby during the first 5 years of that child's life. And as I mentioned before, this is a disease that scares neonatologists so that we don't use the gastrointestinal tract appropriately. And because we don't use the gastrointestinal tract appropriately, many of these babies go on to develop hospital-acquired sepsis because they have intravenous lines in for too long, and they develop bacterial translocation through the gastrointestinal tract and other problems. So here's just one of the studies looking at neurodevelopmental outcome. This is from Dr. Susan Hintz from Stanford University, looking at surgical neck versus no neck. And again, with surgical neck, there's a significant increase in some of these neurodevelopmental problems. So I mentioned before that neck is more than one disease. What has been called necrotizing enterocolitis? Well, we see this disease in term infants, and it's almost always a different disease in term infants than the disease that we see in preterms. We also see babies with isolated intestinal perforations. And prior to about 10 years ago, we used to lump this into one disease called necrotizing enterocolitis. And then we have preterm infants with a classic form of necrotizing enterocolitis. But even with this classic form of necrotizing enterocolitis, there are probably several different pathophysiologic pathways that lead into this. In term babies, necrotizing enterocolitis is oftentimes seen with congenital heart disease, especially with left-sided obstructive diseases such as interrupted aortic arch, or here we see a hypoplastic left ventricle. And that is an ischemic disease that we see in these babies. The heart does not provide enough blood to the gastrointestinal tract, and this causes ischemia to the bowel. Here's a situation where at 12 hours of age, we see this picture, and this is a X-ray right after birth. What happened between birth and 12 hours later? Okay, we see that there's air in the peritoneal cavity, and so this suggests that there's been a perforation of a viscus, and at the time of surgery, this baby was taken to the operating room, and here's what was seen. This is in the distal ileum. This baby had a small isolated intestinal perforation, and this isolated intestinal perforation is not necrotizing enterocolitis. There's rarely necrosis around the area of perforation, and if there is necrosis, it's very minimal. And this is usually not related to feedings, except possibly for lack of feedings, because many of these babies have not even been fed. It's combined to early combined dexamethasone and indomethacin use. Ann Stark, in a study published in the New England Journal of Medicine quite a few years back, showed approximately a 20% incidence of isolated intestinal perforations if you use these drugs together. The increase in isolated intestinal perforations with each one of these drugs alone is not that great. So here we have the study from Ann showing the combination of these drugs leads to very high incidence of these intestinal perforations. Now, when we talk about classic necrotizing enterocolitis, there are these criteria that we use called the Bell's criteria. And these criteria have been around now since the 1970s. And we have a problem with these Bell's criteria. These criteria are broken. Why? Well, stage 1 necrotizing enterocolitis is not a necrotic bowel. We have no evidence in stage 1 necrotizing enterocolitis that there is actually a necrotic bowel. This is a misnomer. This is a non-specific term, and I think that this is a term that we should not be using. We should call something NEC when it actually is necrotizing enterocolitis. In the past, we have called stage 1 necrotizing enterocolitis when we see that a baby has a distended abdomen, has apnea and bradycardia, but no signs of pneumatosis intestinalis, portal venous gas, or anything definitive. Stage 3 also could be isolated intestinal perforation, because when you see a pneumoperitoneum, this has sometimes been called stage 3 necrotizing enterocolitis, but it truly is not a necrotic bowel. So this is something that I think we need to consider using medical necrotizing enterocolitis and surgical necrotizing enterocolitis, and forgetting about the Bell's staging criteria. What causes necrotizing enterocolitis? Well, here we have a combination of factors which include genetics. If you have a set of twins in your neonatal intensive care unit, if they are identical twins, if one twin develops necrotizing enterocolitis, there's a higher likelihood compared to the general population that that baby's twin is going to develop necrotizing enterocolitis. There's a fairly high concordance with development of this disease. The actual genetic marker for necrotizing enterocolitis has not yet been found. We have not found a specific, by various genome-wide association studies, we have not yet found a specific genetic marker for necrotizing enterocolitis, but it is thought that there is a genetic component to this. One of the major underlying factors for the development of the classic form of necrotizing enterocolitis is immaturity. And this is bowel immaturity. We have problems with motility, barrier dysfunction, vasculature, and innate immunity. And also, the microbiome, the microbes in the gastrointestinal tract, appear to play a major role, and I'll talk about this shortly. Classically, it's been thought that hypoxia ischemia plays a major role in the development of this disease. And in fact, much of our treatment there are many studies that are based on an animal model of hypoxia ischemia that we have related to necrotizing enterocolitis. And the way this animal model works, and we have many different variants of this, and this was first developed at Columbia University in the late 1970s, called the Barlow-Pitt method. And what this involves is taking some newborn animals, placing them under hypoxic conditions. And one way to do that is to place them into a plastic bag and close the plastic bag and look at these animals until they turn blue, until they're gasping, until they're almost dead. You take them out of the bag and you put them into a refrigerator and you cold stress them and you feed them, not with their mother's milk, but you feed them with a formula. And those baby animals then develop some kind of intestinal illness that these investigators have called necrotizing enterocolitis. Okay? And I've had a real problem with this animal model for many years, and with that I've written a review article in Biology of the Neonate a few years back called The Myth of Asphyxia and Hypoxia Ischemia as a Primary Cause of Necrotizing Enterocolitis. What's the basis? Why do I think that hypoxia ischemia is not a primary cause of necrotizing enterocolitis? Well, several years ago, I asked one of our postdoctoral fellows to look at the data in our neonatal intensive care unit that related gestational age to average onset of necrotizing enterocolitis, because the classic form of necrotizing enterocolitis did not seem to be occurring early in most of our babies. And what was found was that the really preterm babies, here we see a baby that's at 24 weeks gestation, the really preterm babies develop the disease late. Whereas those babies that are not so preterm, your babies that are 29 weeks gestation, develop that disease a little bit earlier. So if the baby is 24 weeks gestation, the likelihood is that that baby will develop the disease 6 weeks later. Whereas if the baby's 29 weeks gestation, that baby is likely to develop the disease maybe at 2 weeks of age. This has been repeated now numerous times, numerous studies, and there seems to be this period of time, post-conceptual age, somewhere between 29 weeks post-conceptual age to about 32 weeks post-conceptual age, where you see a peak in the development of necrotizing enterocolitis. Exactly what causes this, we don't know. But it's not a disease of hypoxia ischemia. These babies can have very low APGAR scores, but they still develop their disease. If they're very preterm, they develop their disease at 4 to 6 weeks. Okay? So that relationship to low APGAR scores, hypoxia ischemia, does not appear to be a major factor. And this is one of the reasons why I have a major problem with some of these animal models of necrotizing enterocolitis. We have problems with the immaturity of the gastrointestinal tract. If you look at the acid microclimate of the intestine, as I showed you before, the acid is lower in the upper gastrointestinal tract of these babies. Mucin, these babies do produce mucin, but the protein content of mucin is very different. The activity of binding to IgA is not as great in the mucin of these babies. They also have lower motility and lower peristalsis. And so all of these factors work together to create an environment that leads to stasis in the gastrointestinal tract and also a greater capability of the gastrointestinal tract to have microbial stasis. This is the slide that I already showed you, and I'll just pass over this very quickly, again showing low gastric acid output in these babies. And this I also showed you before, that if you use H2 blockers, which decrease that acid even more, you have a higher incidence of necrotizing enterocolitis. Exactly what the mechanism behind that is, we don't know, but we think that it might be a protective mechanism to have acid in the upper gastrointestinal tract. Here's just another study. This is a multi-center study from Italy showing that ranitidine is associated with infections, necrotizing enterocolitis, and fatal outcome in newborns. Again, showing H2 blocker therapy is not a good idea in these babies. And I do know that there are some units that have used these routinely in the past. Necrotizing enterocolitis appears to be an inflammatory disease. We see high levels of various pro-inflammatory mediators in these babies. We see increased platelet activating factor. We see increased IL-6, tumor necrosis factor, IL-1, and IL-8. Where do these cytokines come from? Well, I think that it's becoming more and more clear that most of these cytokines are coming from the gastrointestinal tract. And this is a fact that surgeons have been teaching us or trying to teach us for a long time. The gut is the motor that drives systemic inflammation. And if you have a breakdown of the gut barrier, you have the generation of cytokines coming from the gastrointestinal tract that affects other organs. You have a systemic inflammatory response. Is it possible that the very immature intestine has a greater propensity for producing inflammatory mediators than a more mature intestine? This was addressed by a study at Harvard by Drs. Alan Walker and Nanda Nathakumar. And what they were able to do in this study was obtain small pieces of intestine from abortuses at varying gestational ages and also biopsy samples from older children. And what they did was they took these pieces of intestine, put them into a culture media, and treated these pieces of intestine with lipopolysaccharide. Lipopolysaccharide is an inflammation inducer. And in the fetal intestine, you see here a very brisk IL-8 response compared to the infant. This is IL-8 messenger RNA. This is IL-8 protein, okay, or IL-8 peptide. So in the very immature infant, you see a much greater, a much brisker inflammatory response to LPS than you do otherwise in more mature individuals. So this is telling us that the more immature individual is much more prone to an inflammatory response. Why? Well, one of the possibilities has to do with the intestinal junctions, and I mentioned before that these tight junctions are very important. If they break down, you have increased permeability of the gastrointestinal tract. And here's a cartoon that shows this relationship where you have breakdown of the intestinal epithelium, and with the breakdown of the intestinal epithelium, you have translocation of bacteria or potentially toxic products in the lumen of the gastrointestinal tract that can affect a highly immunoreactive subepithelium, and these cells in the subepithelium generate these inflammatory mediators. These inflammatory mediators do not just affect the gastrointestinal tract. They affect the lung, they affect the liver, they affect the brain. Terry Ender was talking about some of the cytokines affecting oligodendrocytes yesterday, and I think that this is very, very interesting. Is there a relationship between these inflammatory mediators that you see with breakdown of the intestinal barrier and necrotizing enterocolitis and the neurodevelopmental delays that we see in these babies later on? I don't think we've definitely established the mechanism of that, but the association is definitely there. And I talked before about some of the factors affecting the tight junction. And again, tight junctions are very important. I thought to be very important. The breakdown of these tight junctions I thought to be very important in the pathogenesis of the disease. Now, I'd like to spend a little bit of time talking about the microbes in the gastrointestinal tract. And this is an area that our laboratory at the University of Florida has gotten into very extensively over the last several years. We've been able to garner a National Institutes of Health grant to study the microbiome in the gastrointestinal tract of preterm babies. What is the microbiome? It's the collection of microbial DNA in a certain niche of our body. There are several different niches of the body. For example, the nasal cavity, the oral cavity, the vaginal cavity, the gastrointestinal tract, where there are different microbial communities. And we are beginning to find that using the usual culture-based techniques, that we are not able to find most of the microbes that are present in our gastrointestinal tract. And using non-culture-based, DNA-based technologies, sequencing technologies, we are able to see the 70% of microbes that we are not able to culture in our gastrointestinal tract. Now, why are these important? Why are these microbes important in our gastrointestinal tract? We're beginning to find that they play several roles, including roles in the immune system, including metabolic bioreactor roles. And one of the roles, and I think that this has been mentioned in a different way in our previous lectures, one of the ways that these microbes act in the gastrointestinal tract is by stimulating some of the toll-like receptors in our gastrointestinal tract. And a little bit of stimulation of these toll-like receptors has been found to be a good thing. A lot of stimulation is bad. A little bit of stimulation has been found to actually be very protective in the GI tract. I'm not going to get into the details of the studies that have shown this, but work that was done at Yale University by Dr. Medjetov's group was very important in this regard, where they looked at toll-like receptor knockouts. And in these toll-like receptor knockout mice, they found that those animals had a very high propensity to develop intestinal damage, and the repair took a long time in those animals. But they also found out something very similar, very interesting, and this relates to something that we do in the neonatal intensive care unit very often. They found that even with normal toll-like receptors, if you don't have microbes in the gastrointestinal tract, if you don't have those microbes present to tickle those toll-like receptors, that can lead to enhanced sensitivity to injury and diminished capacity to repair. So having microbes in the gastrointestinal tract is very important. How did they get rid of the microbes in the gastrointestinal tract in their animals? They used very broad spectrum antibiotics. We'll get to that shortly. So just the lessons from this study: low-grade stimulation of toll-like receptors can prevent high-grade inflammation and intestinal damage. And there are several studies now being done to look at the specific mechanisms of this. And I'm going to skip these next couple of slides because they are very mechanistic, and I don't want to spend too much time looking at these mechanisms. But this is work that we are doing in our laboratory, looking at systems biology approaches to look at the mechanisms of the toll-like receptor signaling. Do the microbiota differ in babies who develop necrotizing enterocolitis? Is there something different about those babies who develop necrotizing enterocolitis in terms of what bugs are in their gastrointestinal tract prior to the development of their disease? The studies that we're doing at the University of Florida involve 3 different centers. We have 2 centers in Jacksonville, Florida. Jacksonville is a city about 100 miles away from Gainesville, Florida, which is the main university. And we are in Gainesville, Florida. So we have 3 fairly big hospitals that we obtain samples from. So at this juncture, we have been collecting stools for the last 4 years, and I am very proud to say that we have collected stool samples from 800 babies. We have 2 freezers full of stool samples from babies from these 3 different hospitals. And we started to do some preliminary analyses looking at babies who subsequently developed necrotizing enterocolitis and looking at them in comparison to controls. So what happens is we are collecting stool samples from these babies every week. We start from the meconium, then first week, second week, third week, until they develop necrotizing enterocolitis. So we have their stool samples prior to the development of the disease, and we are using something called 16S pyrosequencing to look at the DNA sequence of these babies' microbiome. So here's the first study, and this is a study that we published in PLOS last year. And this is with a small number of babies. And here we have 9 cases and 9 controls. And just a couple interesting points that I'd like you to look at here. The diet. Those babies who were the cases, you see some more FORM. You see the FORM? That means formula. Here we see in the controls a lot more BM, or breast milk. Not statistically significant yet because this is a small number of babies, but suggestive that with necrotizing enterocolitis there is more use of formula. Another very interesting finding, and this gets back to what I talked about before, the lack of microbes in the gastrointestinal tract. And here we see the use of antibiotics. In the cases, each one of these letters represents a different antibiotic, okay? So here we see a lot more letters in the cases compared to the controls. So we are using a lot more antibiotics prior to the development of necrotizing enterocolitis in those babies who subsequently develop the disease. Now, when we look at these microbes, there are different depths of analysis that we can do with 16S sequencing and also the more complicated, more sophisticated metagenomic techniques. But what we do is we look at taxonomy of these microbes. And as you remember, there's a way to look at taxonomy is kingdom, phylum, class, family, genus, order, species, etc. Okay? And looking at the sequencing technologies, we can look at similarities between microorganisms and get all the way down to a genus and species level doing this sequencing technique. Now, these colors represent the taxonomy at a phylum level. Okay, so this is very gross level. And these colors represent different phyla. Now, we have 4 major phyla of microbes in our gastrointestinal tract, each one of these represented by these different colors. And here we look at before the diagnosis of necrotizing enterocolitis, 1 week before the diagnosis, and this is within 72 hours of diagnosis. And these are the controls. With the controls, as you would expect, there's no difference. But in the babies who develop necrotizing enterocolitis, this is 1 week before the diagnosis, looks a little bit different than the controls. And this is within 72 hours of diagnosis. What we have here is this bloom of this purple. This purple are the Proteobacteria phylum. The Proteobacteria are a phylum that is also seen in association with inflammatory bowel disease in older children. Those Proteobacteria include a lot of the pathogenic species. So this is at what we see at a phylum level. When we dig much deeper, and this is what's called a heat map, and here we're beginning to look at the genus and species level. And I'm just going to show you a little representation here of the heat maps that we're seeing. And this is a heat map that shows the controls, the cases up here in the dark blue and the controls in the light blue. And this is 1 week before the diagnosis. We see some differences in each one of these. These are different genus and species of microbes. We see some differences 1 week before. And then within 72 hours, we see some major differences. Some of the microbes that pop up within 72 hours, here we see no microbes here, but some of these microbes that pop up within 72 hours are very interesting because when we take these sequences and match them on against known sequences on what's called a blast analysis, we find that these microbes don't even have a name yet. Okay? These are microbes that are closely related to the coronabacteria viruses. To the coronabacteria genus. They're closely related to Klebsiella, but they do not have a specific name. Okay? So they're very similar to some of these species that have been identified by culture, but we still don't even have a name. So a lot more work needs to be done in this area. Now, what happens in our neonatal intensive care unit. And this gets to the point that I was trying to make before. In the animal studies, what do we do in most of our neonates? The most commonly used drugs in the neonatal intensive care unit are ampicillin and gentamicin. And Dr. Poland was getting at this yesterday, that we use ampicillin and gentamicin in approximately 90 to 95% of our very low birth weight babies. For various reasons, we're very concerned that these babies might have pneumonia. We're very concerned that the reason that they were born prematurely might have to do with infection. And so we are very cavalier in using antibiotics in these babies. Well, what happens with this antibiotic usage? Well, this is a study that was done in Switzerland and looked at antibiotic treatment and gastrointestinal tract development in baby rats. These baby rats, the treatment group was treated with 100 milligrams per kilogram per day of Clomoxyl, very similar to amoxicillin, and compared to a saline control. They looked at the bacteria after 1 week in the gastrointestinal tract and found that all the bacteria were significantly decreased, especially the lactobacillus. And then they did an Affymetrix gene microarray on the intestine looking at RNA expression. And they found that 10 to 30% of the genes undergoing maturational changes showed modulation by the antibiotic, so that their normal pattern of maturation was either accelerated or slowed down. The MHC genes were also markedly affected, and the MHC locus is one that's very important for tolerization to luminal antigens. What about our preterm babies? Well, this is a slide that Dr. Poland showed you yesterday, and he said that there are 3 studies now showing that the use of antibiotics, especially the prolonged use of antibiotics, increases the likelihood of development of necrotizing enterocolitis. So this is one of the things that I think we need to think about very seriously in terms of what we do routinely in our preterm babies. What about some of the preventative measures that we can use to prevent this disease? Well, certainly human milk. I think that it is very clear that human milk can prevent necrotizing enterocolitis. The use of donor milk may not be quite as clear as the use of the baby's own mother's milk, but certainly that is a very important factor to prevent necrotizing enterocolitis. Careful advancement of feedings, okay? The studies that have looked at very rapid advancement of feedings do suggest increase in necrotizing enterocolitis, but careful advancement of feedings, I don't think we have a specific number, but somewhere between 20 to 35 milliliters per kilogram per day advancement of feedings is probably maximal, somewhere in that range. There are some questionable measures, formula acidification, IgG, IgA, the use of oral antibiotics, that has pretty much gone by the wayside. Anticytokine therapy, there's a lot of excitement about the use of probiotics. How many of you are using probiotics in your neonatal intensive care unit? Okay, I see quite a few hands going up. This is a very interesting and very controversial area, and I think that we still have to do a lot of work to actually be able to use probiotics safely in these babies. But here's the study showing human milk, improvement or decrease in necrotizing enterocolitis. The classic study by Dr. Alan Lucas showing a 5-fold decrease in necrotizing enterocolitis with human milk use. It would be very important for us to be able to have both diagnostic and predictive biomarkers for development of for this disease. Radiographs, seen here, are pretty clear that there are some real problems going on. This baby has portal venous gas. This baby has free air. So those are markers that are telling us that there is definitely something bad going on in the gastrointestinal tract of these babies. These babies likely have significant necrotizing enterocolitis. Oops. However, what about these x-rays? They don't look normal, do they? They look very abnormal. But do we see pneumatosis intestinalis? Do we see portal venous gas? No. So we can sometimes get into a conversation, maybe even an argument with our pediatric surgeons saying, I think that there's something really terribly wrong with this baby. And the surgeon says, you know, we're not seeing perforation, we're not seeing portal venous gas, we're not seeing any definite signs of necrotizing enterocolitis, so I'm not going to operate on this baby. But these definitely look like very abnormal x-rays. If we had better diagnostic biomarkers, we could be able to make a better decision on what to do with these babies. So we need better diagnostic biomarkers. I'm just going to skip through this. And what are some of the biomarkers that we commonly use? We use platelets, C-reactive protein, white blood cell counts. And this is work that was done in Holland by Dr. Thils and colleagues, very interesting study, looking at platelet counts in necrotizing enterocolitis. Here is no NEC, here is NEC, and no difference in p-values. Here is CRP, no NEC, NEC, no significant difference in p-values. White blood cells. We do see lower white blood cells with necrotizing enterocolitis, but this is very nonspecific because you might see the same thing with sepsis. So they started to look at some other biomarkers, and the three biomarkers that they looked at were claudin, intestinal fatty acid binding protein, and calprotectin. Claudin, if you recall, is one of the three major intercellular proteins that is involved in holding tight junctions together. Claudin is a water-soluble molecule, and with breakdown of the tight junctions, you find more claudin in the bloodstream and in the urine. And here we see, with necrotizing enterocolitis, more claudin in the urine of the babies who develop necrotizing enterocolitis. Calprotectin is not seen in the urine, but it's seen in the stools. And this is released by intestinal neutrophils with intestinal inflammatory damage, and it can be used as a marker for gut wall inflammation. And here we see, with necrotizing enterocolitis, lower levels of calprotectin than with necrotizing enterocolitis. The problem with stools, with stool analysis, is that you are at the mercy of a baby pooping. Okay? If the babies don't poop, you don't get the calprotectin. You can't get the calprotectin levels. These babies will urinate a lot more readily, and so if you have a biomarker that's in the urine, that would be better. And here is the intestinal fatty acid binding protein, also a small water-soluble molecule that's seen in primarily in the enterocytes, and with breakdown of the enterocytes, you see an increase in fatty acid binding protein in the urine. And here with necrotizing enterocolitis, we are seeing more fatty acid binding protein in the urine. And looking at these in terms of sensitivity, specificity, likelihood ratios, etc., the intestinal fatty acid binding protein and claudin seem quite good in terms of their diagnostic value for necrotizing enterocolitis. So I think that these are not yet commonly used in clinical practice, but I think that they're showing a lot of promise for potential use in the future. What about predictive biomarkers? We'd like to be able to have a predictive biomarker that would tell us which baby is at greatest risk. But we'd like this predictive biomarker to be non-invasive. We don't want to be drawing blood on every single baby in a neonatal intensive care unit to be able to find out if that baby is at higher risk. So what some places are beginning to do, including our study, we have started to do buccal swabs. This is not a preterm baby, but it just reflects what we do in our preterm babies. We get buccal swabs in the preterm babies, and we've taken a biomarker approach using two-dimensional gel electrophoresis, and we have discovered now approximately 37 proteins that are either down or upregulated with necrotizing enterocolitis, and we have done a systems biology approach, and this is just very, very complicated appearing, but what this does is show us where these proteins fit in different categories of physiologic and inflammatory processes, okay? So this helps us determine which proteins we should try to decide to look at, okay? It's very expensive to do two-dimensional gel electrophoresis. You don't want to be spending $10,000 for one analysis. You want to be spending maybe just, maybe €1 or two, or $1 or two on an analysis. Okay, not $10,000. So you want to narrow this down to maybe just a few proteins that would be of interest. And so doing much simpler tests like ELISAs would be the approach to take. And one of the proteins that has really popped up of interest, and this is from a paper that we just submitted for publication, IL-1 receptor antagonist appears to be very low in those babies who develop necrotizing enterocolitis. And this makes a lot of sense because IL-1 is an inflammatory mediator that is found in very high concentrations with necrotizing enterocolitis. And if you have a low level of the receptor antagonist, that will not counteract the effects of the IL-1. So we find this several weeks before the development of necrotizing enterocolitis, but we still have a lot of validation to do with this particular technique. So I'd like to just stop here with some take-home messages. NEC is more than one disease. The pathogenesis of classic NEC is multifactorial, but there's some factors, such as the gut microbial ecology, which may become much more important than others. And predictive and diagnostic biomarkers are needed for targeted prevention and therapy of this disease. Thank you for your attention. Necrotizing enterocolitis into medical